I'm going to try to say the name of the next speaker. I'm going to be bold. Felicien Triboulet. Impact of additional genetic variants in the course of ECD, a multicentric longitudinal study of 445 French patients. So the study is from France. Welcome.
Okay, hello everyone. My name is Felicien Triboulet. I'm an internal medicine resident in Pitié-Salpêtrière Hospital in Paris, France. And I thank the ECDGA for allowing me to present this very interesting research about clonal hematopoiesis and ECD through a cohort of 445 patients in our department. So as you know, ECD refers to a rare clonal hematopoietic neoplasm driven by MAP kinases signal pathway activation. And its prognosis has been deeply modified by conventional therapies or targeted therapies with very good overall survival and response. Clonal hematopoiesis is a subpopulation of bone marrow cells who acquired some variants in many genes involved in many cells function. We distinguish many categories depending on the percentage of VAF and the presence or not of cytopenia. And we know that CH is implicated more and more in many conditions. It was described that with a CH you have, in parallel, it was described that there was an increased burden of myeloid neoplasm in ECD. There are some data about CH in ECD, especially the fact that there was approximately 40% of CH in ECD, but its consequences are not well known, and that's why we wanted to do this work by describing these variants to look for association or not between CH and ECD characteristics. And we wanted to study the evolution of main variant VAF under main treatment, especially targeted treatment. So it was a retrospective longitudinal study with 445 patients recruited from February 2001 to April 2025 in our internal medicine department in Pitié-Salpêtrière Hospital. And we collected the data about many clinical variable, age, sex, cardiovascular burden, many information about ECD medical history, disease localization. We look especially for the presence of solid or hematologic malignancies. And we perform in not all patients, but a majority of patients, bone marrow aspiration. And we assess for the presence of CH thanks to myeloid panel genes who comprise 65 different genes. And we also look for mortality and survival analysis. Without any surprise, it was especially men with first ECD manifestation age approximately at 55-year-old. There was very important prevalence of cardiovascular risk factors, smoking, diabetes mellitus, dyslipidemia, hypertension, and coronary artery disease. Here you have the details of the clinical radiological manifestations of the disease, many long bone hypermetabolism, and almost 40 to 50 patients who had heart involvement or CNS involvement, So it was, for some patients, it was quite severe. What was the driving mutation? It was mainly BRAF V60E variant, followed by MAP2K1, and the large majority of patients were treated for their disease. Only 10% were not treated because of the lack of severity, and half of patients treated got conventional or pegylated interferon. You have approximately 20% of patients who had a solid neoplasm, especially skin and prostate, and more than 20% who had hematologic malignancies, especially myelodysplastic syndromes and myeloproliferative syndromes. Excuse me. We had 286 available myelogram at baseline. So there's a mistake, it's approximately 2/3 of patients. And from the 2/3 of these patients, 60% had CH with a mean number of variants of 2.3. And what we see that patients with hematologic malignancies were older when we identified CH. And when you see the mutational landscape between all the patients on your left and especially in patients without hematologic malignancy, you see that it's almost the same with ISXL1, CBL, DNMT3A, and RAS at TET2. When you compare 113 patients with clonal hematopoiesis to 106 patients without clonal hematopoiesis, you see that from all these risk factors in univariate analysis, you see that only a later onset of disease is by itself associated to the presence of CH. The other part of the work was to try to see what was going on in the VAF variant for some patients who had bone marrow aspiration. Data are very poor because you have only a few patients who had CH through follow-up. And in these patients, you had to see those who were treated. So we have very few effective, and for some treatment, it was almost impossible to analyze the data. But from patients with CH without hematologic malignancy or hematologic malignancy, there is no clear effect of targeted therapies on CH. We want to see, because here it's CH in bone marrow, and we wanted to see if CH was present in tissue in where the diagnosis of ECD was done. And for this work, we had 28 patients where CH was researched. And you have the detail of the number of variants. But you see that in for 67, it's not the number of patients, but the number of mutation. You find the same variant in bone marrow and in tissue, with a lower VAF of CH in tissue. 35% of mortality, half of the death imputed to ECD. And again, you see that CH is an independent risk factor of mortality with a hazard ratio of 2.15. And to conclude on the results, you see here with the survival analysis that mortality in patients with hematologic malignancies was reduced compared to patients without hematologic malignancies. And at your right, you see that in patients without malignant hematologic malignancy, there was a difference in survival in favor of patients who didn't have CH. So we have the impression that CH is very important, has a very hard impact in the course of ECD, because it was already shown in the literature that CH was associated with cardiovascular burden. Here in the cohort, there's a high proportion of patients with cardiovascular risk factor. We saw that CH was an independent mortality risk factor, and it was already shown that CH may be like a first hit before getting BRAF or MAP2K1 variant. At the opposite, there were no clear influence of targeted therapy, but maybe it's just due to the lack of data and the missing myelogram during the follow-up period. And the crucial role of CH one of the hypotheses that it could contribute to the local damage, maybe through inflammation, through dysregulation of cell functioning, leading to organ damage, and maybe by increasing mortality. So our study had many number of patients in translational research, but at the opposite, one of the limits is the fact that we perform bone marrow aspiration, so it can be seen like a little bit invasive, but it's like an innovation. And other limit, the lack of some data. So CH is frequent in ECD, even without underlying hematologic malignancy. A late onset of ECD is an independent risk factor of developing CH. I already talked about the prognostic value of CH in ECD, and we showed that it was an independent mortality risk factor, but there was no clear influence of treatment on CH. Thank you for your attention.